Well, in most patients, we start with what we call conservative treatment, which means non-operative treatment. And I would say the vast majority of patients do very well with that. Everybody, almost everybody, had some episode of back pain at some point, and with rest and some stretching exercises and some very light medication, do well, and the flare-up disappear and they go back to their normal life. So whenever we see a patient in the office with an acute back pain, we always have to give them a chance to heal without any surgery, and then they have some other option.
Well, thankfully, most treatment options are conservative care, which means physical therapy, exercise, stretching, ice, heat. So, for example, if somebody were to injure their back, the first thing I'd recommend is stop what you're doing, rest, put ice on the area, maybe take an Advil, that sort of thing. That'll take care of most back pain episodes. Beyond that, you'd get involved with physical therapy, even chiropractic care to treat back pain. And those things work most of the time.
Sometimes we can do some injection, we can give some stronger medication, do some physical therapy. There's a lot of options. I would say that 90% of the patients we see in an office like this one, which is specialized in spine problem, 90% of the patients are not candidate for surgery. And within this pool of patients, we once in a while see patients who don't respond at all to all this technique and still have severe pain after a while, and we start talking about surgery. And that's where we can give them some option.
Well, we consider surgery in patients who obviously fail all of these other treatments after either a good long period of time, at least 6 months, or if they develop some sort of neurologic problem, for example, numbness or weakness, development of a foot drop, which means that you can't use your foot normally when you walk. These are the common types of things that can occur in relationship with back problems. The other sort of thing that doesn't happen very often is a bladder or bowel problem. So these are the things, and in addition to this severe pain, may indicate some sort of surgical treatment. The most common type of surgical treatment for back problem is a microdiscectomy. Microdiscectomy is an operation where you remove a piece of a herniated disc. These cushions can sometimes herniate, which means a little piece of the disc can push out against a nerve, and that can cause pain down into the leg. So that would be the most common type of surgical treatment.
The main option until recently has been spinal fusion, and when you do a spinal fusion, the concept of spinal fusion is that motion hurts in this disc, so we just have to stop the motion.
It may limit their personal life, their home life, their ability to take care of their children, for example. In other words, a disabling condition, and that is generally caused in most cases by a degenerated, painful disc. Traditionally, if patients have failed non-operative care, then a spinal fusion is done. A spinal fusion is when we actually remove the disc and place a bone graft where the disc used to be, and what will happen is that bone will grow from one vertebrae to another. And what that does is stop the motion of that disc.
And it works. In a sense, it works. It provides patients with a significant relief.
Well, the literature the medical literature on spinal fusion success ranges in terms of patient satisfaction from 60 all the way up to 90%. And a lot of it really depends on the specific situation the patient may have. If they have a single bad disc and the other discs are healthy, it generally works quite well.
The downside are it's long recovery, and the hospital stays longer, the return to work is longer because you have to wait for this fusion to heal, which takes several months. And also the other downside is that by blocking the motion at this one level, you increase the stress on the adjacent levels, which create potentially in the future the same problem at another level of the spine. That doesn't happen all the time, but it probably happens very often after 5 to 10 years. That's where we came up with this new concept of artificial disc.
Well, total disc replacement, or otherwise called artificial disc replacement, is a procedure that has been done in Europe for almost 20 years.
The FDA started a study in this country in 2000, and the FDA selected 14 centers in the country, and we are one of them, to do this experiment. And the study is over now, and the FDA should approve it hopefully very soon.
Well, DePuy Johnson & Johnson has the Charité prosthesis, which is the closest to FDA approval and will likely be approved very soon.
The artificial disc is a concept that came from orthopedic surgeons who have done knee and hip replacement. And the idea was, now the motion in the spine hurts, but instead of blocking it, we have to remove the organ that creates the pain, which is a disc, and replace it with a new one.
Instead of fusing the disc and stopping it from moving, we actually place an artificial disc in that space where the bad disc was, and that allows that disc to continue to move. We think this is a revolutionary change in the treatment of these sorts of back disorders because it allows motion to continue. It allows the patient to recover much faster than fusion, and then hopefully prevents or decreases the chance of this adjacent level problem that we see with spinal fusion.
The results are that the artificial disc gives better result on the back pain than the fusion. The recovery is quicker, and the complications are less common.
The risks of doing artificial disc replacement are very similar to spinal fusion. A lot of spinal fusions are done through what we call anterior approach, and that's through the abdomen. So there are surgical risks that are very similar to both. Fortunately, they're very rare to have any problems associated with the abdomen or the abdominal contents in either procedure, provided you have an expert team of surgeons with experience.
I've done a professional stuntman who's back to full activity, and he's been back to full activity after 3 months after surgery, and the level of stress he put on his back is just unbelievable. And he just gave me some tape of what he's done recently. It's hard to believe that he's able to do that after such an operation, and the disc is doing very well.
In the Cedars study, which was over 100 patients, we had 91% of patients return to work within 3 months, most of them returning to sedentary type of jobs in 4 to 6 weeks, compared to spinal fusion, which is generally twice as long.
I've done a Navy pilot who is back to full activity. We've done some high-level athletes. So I would say that if these people can go to their normal routine activity, I would say that the most common people who just exercise for pleasure on weekend can basically do whatever they want.
What we've seen and what we have looked at in the study that is being presented and published is that in an evaluation of over 200 patients, in comparing them to patients with spinal fusion in a randomized study, the patients with artificial disc replacement had less pain, and had a more rapid recovery and return to normal function, and a quicker return to more active types of jobs. And we have many examples. For example, I had a Los Angeles policeman return to his job within 3 months, and he never would have been able to do that with a spinal fusion. So we are seeing patients return to very active lifestyles.
Ideal candidate is a patient who is not too old, and with, which means basically with a good quality of bone. Severe osteoporosis being a contraindication for this procedure. With a single level disease, which means only one disc should be affected by the disease. After we've tried at least 4 to 6 months of non-operative treatment, always give the patient a chance to avoid surgery.
We've seen that as we've developed experience and had a higher caseload of patients, the results are getting better and better. We generally feel it's going to take the surgeon 10 to 20 cases to feel comfortable doing the procedure. And the surgeon works with a general surgeon or a vascular surgeon because this is a procedure done through the abdomen. And so with that surgical team, we feel the procedure can be done safely with good results.
This is probably one of the most important breakthroughs in spinal surgery over the last 50 years. And this procedure will probably gradually take over most indication of spinal fusion, not now, but in the future. And I hope that the patient will take advantage of it as much as they can. And any patient who is now a candidate for spinal fusion is not necessarily a candidate for artificial discs, but should definitely check it out. Most insurance do because they understand, we have to talk to them because they understand that it's, the expense for them is much less, the fusion, because the implants are, the cost of the implant is comparable to the one of to the fusion, but the hospital stay is shorter and the return to work is much quicker.